Muhihi. I work with the Africa Academy for Public Health as a project coordinator. This afternoon I'll be presenting to you a protocol of our project that we've been implementing in collaboration with the Muhimbili University of Health and Allied Sciences, the Fakara Health Institute, and Harvard T.H. Chan School of Public Health. The project is about calcium supplementation among pregnant women to reduce pre-eclampsia and preterm delivery. So hypertensive disorders contribute significantly on maternal morbidity and mortality, as well as preterm delivery. They contribute they complicate 6 to 7% of all pregnancies, and if it is primigravida, then they complicate up to 11% of the first-time pregnancies. Evidence has already shown that giving calcium supplements to pregnant women reduces the risk of pre-eclampsia by more than half. It does also reduce the risk of preterm delivery as well. As a result, the WHO recommended calcium supplementation to all pregnant women at a dose of 1,500 to 2,000 milligrams per day in 3 to 4 divided doses. However, this recommendation has not been adopted as a standard of care in most low and middle income countries, mainly due to challenges related to high cost of the calcium supplements, but also the complexity of the staggered dosing, which is 3 tablets per day, especially in our settings where anemia is also prevalent and you need a woman to take separately calcium supplements and iron supplements. And the last one is the related to logistics. The calcium supplements are big, and so they pose logistical challenges in terms of storage, but also transportation across. So this study aims at generating evidence of a lower dose calcium supplement to reduce pre-eclampsia and preterm deliveries, but also assess the barriers, enablers, and acceptability of the WHO recommended dose, which is 1,500 milligrams per day among pregnant women in Tanzania. In terms of methods, we have 3 components. We have a randomized clinical trial. This is a double-blind, and the sample size for the clinical trial is 11,000 pregnant women, half of whom are randomized to receiving the standard WHO dose, and the other half is randomized to receiving the lower dose, which is 500 milligrams per day. The second component is an observational cohort where our women are recruited and followed up without being given any calcium supplements, and the sample size here is 1,000. The last component is the implementation cohort, where women are recruited and given an open label calcium supplements and followed up in routine antenatal care without any active follow-up of the participants. And the sample size here is 250 participants. These are the eligibility criteria of the participants, which I won't go into details, but they are adults aged 18 years and above, non-paras with a gestation age of 20 weeks or less, so that they have enough time to take the supplements for you to see the outcomes of interest. And for the clinical trial participants, they are randomized, as I said, to receiving either standard dose or lower dose, and they are followed up until delivery to 6 weeks postpartum. But the calcium supplements are only given during pregnancy and not after delivery. Because this is a randomized clinical trial, both groups receive equal burden of the calcium supplements. So each group takes 3 pills. For the standard group, each tablet has 500 milligrams. For the lower dose, the first tablet has 500 milligrams, and the other 2 tablets have placebo, they have 0 calcium. And we have been following the participants, as I said, throughout pregnancy until 6 weeks post-delivery. So where are we? As I speak, we have already completed the recruitment of all 11,000 pregnant women for the clinical trial. We were able to screen more than 45,000 women. For the observational cohort, we have already completed recruitment of 1,000 pregnant women that are being followed without being given calcium supplements. And we are now finalizing recruitment of the 250 participants for the implementation cohort. In terms of follow-up, we have a follow-up rate of 91.9% for the clinical trial and 97.8% for the observational cohort participants. And we continue to follow the participants until December 2022 for the clinical trial and February next year for the observational cohort. The implementation cohort will end probably in April or May. So we hope that if we are able to find that the lower dose is non-inferior to the standard dose, then it will enable programmatic adoption of this important intervention, as well as uptake and adherence. A similar study is also being implemented in India, and we hope the two will inform programs in the two countries. Thank you very much.